Good evening, everyone. My name is Alan Ainsworth, and I'm the CEO of Bateman Horn Center. This is our monthly education meeting, and we want to welcome you. The first thing I want to say is that last week, the Supreme Court made a pretty large decision about the Affordable Care Act. I did it again. When I think of ACA, I always go to Affordable Care Act, rather the Accountable Care Act, which is the predecessor for the ACA use. So the Affordable Care Act is the legislation that was passed some years ago that is supposed to change the way healthcare delivery occurs. And you'll be hearing quite a bit about that and the implications of it from these three people. The Bateman Horn Center, the reason I bring this up is that the Affordable Care Act pushes quality health care, and we'll be hearing a bit about quality health care from these individuals as well. What are the implications of the Supreme Court's decision last week? You're welcome to ask more questions, but I expect that these three people will be filling in these gaps as well. I keep referring to these three people. This is the Utah Health Policy Project. Matt Slonaker is the executive, the other executive director, rather than CEO. Matt comes from Montana, and he has a degree, a Juris Doctor degree. He's actually a lawyer by training. Spent some time in Washington, D.C., working with policy at the national level. Then when I met him in New York, he was working for a Healthcare for Homeless project in New York City. And we attended a couple of conferences together, and I got to know him, and then was pleased to see that he came to Utah and ultimately accepted the job as the executive director of the Utah Health Policy Project. Riley Curtis is a Medicaid and policy analyst, is that correct? Yeah. And she comes from Utah, and we're really curious to see what she has to say about policy analysis at the local level and the state level. Jason Stevenson is the Education and Communications Director at UHPP, and he manages public outreach, does social media, communication strategy, and probably several other things. So I'm not going to take any more time, but I welcome you and look forward to listening to you. And they'll spend about 45 minutes on the slide presentation, and then you're welcome to answer questions afterwards. Thanks.
Thanks, Alan. Thank you for that nice introduction and explaining a little bit about Utah Health Policy Project. Like Alan mentioned, I'm the executive director. My name is Matt Slonaker. I've been with Utah Health Policy Project for about 3 years, and as Alan mentioned, before that I was in New York City, and before that even, I was working on the Affordable Care Act in Washington, D.C. I worked for Senator Max Baucus, who was the chair of the Finance Committee at the time. So let me just tell you a little bit about the Health Policy Project, just to start us out here. So, I think it really is important to look at a mission statement of an organization to really understand what they stand for, what are their goals, what motivates that organization and its staff. And just to read the mission statement, Utah Health Policy Project is a 501c3 nonprofit, nonpartisan organization advancing sustainable healthcare solutions for underserved Utahns through better access, education, and public policy. And I want to draw your attention to a couple key parts of that mission statement. The first part I want to say is nonprofit. Now, we all know that healthcare is a very partisan subject these days, but we really hold true to that nonpartisan point of view. I think, Jason will talk a bit about how we talk to the community when it comes to the Affordable Care Act. We really cut through politics as much as we can and get just to the facts. And, it's hard to do, but I think it's a goal worth trying to achieve. The other part I want to draw your attention to is underserved Utahns. That's a little confusing. Why do we choose that word? After all, many of us could deem ourselves underserved, but who we really are talking about are low-income Utahns, the working poor, Utahns that live in disparate communities, folks of multicultural, multinational backgrounds, refugees, LGBT. Those are the folks we really think about as being underserved. Those that are underinsured, folks that don't have insurance that works for them very well, or folks that are uninsured, folks that don't even have health care coverage. That's who we really think about when we work in the community at the state and local level, and the national level as well. So what do we do? I want to go over this a little bit and kind of color part of the conversation you'll hear from my co-presenters here today, and Jason and Riley, and kind of set the tone. So what do we do? The first thing is really something that we call advocacy or advocacy training. And advocacy training, what does that get at? Well, I think of it as helping the community help themselves, helping the community better understand the political system that they work in, and what kinds of things, for a group like yours, what kinds of things you could do to make an impact, to have folks better understand your cause, better understand the disease, making sure that folks that are patients of the disease or that are and really wanting to make a difference, not just for themselves, but for the group at large, how they can make that difference. So today, we'll hear a bit about how that can happen and do a little advocacy training, we like to call it. Community education, it kind of really goes well with advocacy training. Part of what we're going to do today is educate the community. You in the room here hopefully will have a better understanding of the Medicaid expansion debate, and you'll also have a better understanding of the Affordable Care Act. 350 people plus, hopefully out there in the cyber world, will watch this program, and maybe even more, and learn a little bit about the Affordable Care Act and Medicaid expansion. So we really consider that community education, meeting people face to face, helping them better understand the choices in the healthcare system, things that they may be able to make a difference on, or at least help their own families with the new information that they've gained. Coalition building, this is an interesting one. So after you've sort of got the advocate training and the community education, really understand the cause and how to make a change, the best thing to do next is to build a coalition, to build a collection of like-minded individuals to advocate for the cause with a united front. It really makes a difference. I'd say with more numbers comes more power and the greater ability to sway the decision makers that may have an impact on the future of your cause and the patients that are experiencing the disease that you support. Other piece I want to talk about, and I should have probably talked about that a little bit before coalition building, but the other thing that we bring to the table is policy analysis. So this stuff is really hard. Healthcare is probably one of the hardest things to understand. How to understand your insurance, how to understand the Affordable Care Act, how do you understand Medicare, Medicaid, CHIP. We really sort of try to cut through a lot of the very technical terms, the acronyms, and educate the community under this backdrop of policy analysis. So we analyze the policies and we cut it to a format that folks can understand. That's really what we think about when we talk about policy analysis. So, and I wanted to then now talk a little bit more directly and once again hopefully shape the conversation that we'll continue to have as the presentations go on beyond mine. And I want to talk a bit about the challenges facing the myalgic patients, so the ME CFS patients. So I think we should think a little bit about what parts of the Affordable Care Act does the ME CFS community care about, or what parts affect the ME CFS community. We've done a little thinking about that. I think we have some suggestions. This group and this disease is somewhat new to our organization, but we're always willing to try to draw parallels to other organizations we've worked with to help improve those organizations' abilities to make a better policy environment, a better healthcare environment for their patients. How does the Medicaid expansion, so we talk about the Affordable Care Act, but we're also talking about the Medicaid expansion. How might that benefit the ME CFS community? I think some of the reasons are pretty clear-cut, and some of them maybe are a little less clear-cut. So we'll try to give you a few suggestions and also take questions at the end about how perhaps you can improve some of your solutions that you're pursuing for some of these challenges. And finally, how can you activate as a community and get involved? We'll talk a bit about that. So with that, I want to introduce our two presenters who are going to talk about the subject matter of today's conversation. I was just here to sort of shape, hopefully, what the conversation will look like. First off, we'll have Riley Curtis. She's the, as Alan mentioned earlier, Medicaid policy analyst at Utah Health Policy Project, and she's going to talk about the Medicaid expansion, Healthy Utah Plan, Coverage Gap Solution, Utah Cares. We have a lot of different names for the various options for the coverage gap in Utah. So she'll try to cut through the morass there and really drill down to help you understand what's going on. After that, we'll have Jason Stevenson. He's our ACA policy expert as well as our communications director. So you'll find that he's a very, very good presenter. He's also really good at cutting through that morass and getting to the facts and hopefully helping provide information for patients experiencing ME/CFS. So with that, I'll turn it over to Riley Curtis.
Hi, so my name is Riley Curtis, as Matt indicated. I am the health policy analyst for the Utah Health Policy Project, and I work with Medicaid, people receiving Medicaid policy, and I work directly with consumers who fall into the Medicaid coverage gap. So, you might ask, what is the Medicaid coverage gap? What is this that we've been talking about for a little over 3 years now? So the Medicaid gap is about 53,000 Utahns. These are low-income Utahns who do not qualify for Medicaid, and they also cannot receive health insurance on healthcare.gov. Jason will go over the subsidies and how they work later, but just for all intents and purposes, they cannot qualify for help on healthcare.gov. They also don't make they earn too much money or otherwise don't qualify for Medicaid in the state of Utah. And that's because Utah is designed as a categorical program, so it's not just that you are low income that you will qualify for Medicaid. You have to be low income plus fit into a category, so a pregnant woman, or be a child, or have a disability. And my understanding is that it might be difficult, especially for a lot of people who are going undiagnosed with symptoms like, or diseases like fibromyalgia or the like, you know, because we have a person in our office who has a neurological disorder. She doesn't quite know what it is, but she needs to see specialists to get a diagnosis, to get treatment. And so without that disability ruling, that diagnosis, she can't get on Medicaid right now, so she's in the Medicaid coverage gap. So let's just walk through real quickly. There's two main groups who fall into the Medicaid coverage gap. So of the 53,000, about 1/3 of those are parents with children, dependent children. Let's run through a family of 3 in Utah. That would be anyone who earns from $0 to $10,000 annually. They do qualify for Medicaid in the state. But after they're above that $10,000 threshold, so in between $10,000 and $20,000 annually for that family of 3, they fall into what's called the Medicaid coverage gap. So they earn, right there, too much money to qualify for Medicaid, but they earn too little to get help on healthcare.gov. The second group, so 2/3 of that 53,000 are adults without children or dependent children. So they actually don't qualify at any level in the state of Utah for Medicaid. So they can earn anywhere from $0 to about $11,700 annually, and they are falling in that gap. They can't qualify for Medicaid because there's none offered for them, and they earn too little to qualify for help on healthcare.gov. So who is in the Medicaid coverage gap? So over the last 3 years, we've had a couple studies that have been done that really dive into what does this gap look like? Who are these people who fall in this gap? And so we know that 2/3 are over the age of 25. One that I don't have in here is about slightly less than half are females, and my understanding is that this should I call it a disease? This disease, sorry. Okay, so this disease, like a comorbidity. Okay, so this disease really, from my understanding, affects women, largely affects women, and so about slightly less than half are females in this coverage gap. Half are part of families, with 1/3 being parents. I talked about that. And then 1/4 identify their ethnicity as Latino or Hispanic. Household composition. So, you know, they're living, all of us are part of families, but what does their actual household look like, their structure? So over 4/5 are part of families with children, over 4/5 of families with children in the home have at least one working adult. So think of a parent, like 2-parent household with 1 child, maybe one of the parents is working, but the other is not, and the family is still in the coverage gap. And that's really, you know, when we talk about families, this picture down here with the family structure, that's Wendy Henley, and she lives in Provo, Utah, and she's a single mother with children in the home, and she finds herself in the coverage gap. She is a student going to school for social work at the University of Utah, but she, you know, just hopes and prays that every day she's going from, you know, Utah County to Salt Lake, she's not going to get in a car wreck or something might not happen to her because she doesn't have insurance to cover that catastrophe. And then for those not in the labor force, the dominant reasons cited were taking care of family or being a student like Wendy. So if you've got caretakers of individuals who are aging, like aging parents, or you've got someone taking care of someone with a disability, those folks are giving up their jobs to take care of family members, and so they're finding themselves in this coverage gap. And then labor market status. So over 2/3 of the coverage gap are working. So about 62% are working a full or part-time job. And this is the case, Kylie Topont, she's in the middle there. She actually works a part-time job right now. She has what she thinks and what doctors think are Crohn's disease, but she can't work enough hours because her body won't let her to get full health insurance. But she also can't get a diagnosis to get on Medicaid disability because she doesn't have health insurance. So she is working a part-time job. And then over 40% of those working part-time reported cut hours, or they couldn't find full-time employment. So the Medicaid expansion, as I've kind of alluded, we've been working on this for a long time. I've left 2 years actually off of this timeline because otherwise it'd be really difficult to look at. But let's just start briefly. In 2010 was when the Affordable Care Act passed, and then a lot of states, including the state of Utah, challenged the constitutionality of the Affordable Care Act. And so in 2012, the Supreme Court came down and said, in fact, we will uphold the Affordable Care Act, it will be the law of the land, but we're going to throw a curveball and make Medicaid expansion a provision of the ACA optional for states to implement. So a lot of folks might think that this is a Affordable Care Act problem, but really this problem, this Medicaid expansion, Medicaid gap, was created by the Supreme Court ruling in 2012. So it made Medicaid expansion optional to states instead of mandatory, and that leads us to our timeline here. So in 2013, I'm just going to go through these orange dots here, and you can look at the later, kind of fill it in afterwards, but a lot of folks now will ask me, why can't Governor Herbert just implement Medicaid expansion? That's what other states have done. Their governors said, we want to take care of our people in our states, so why can't Governor Herbert do that? Well, that's because of this bill passed in the Utah legislature back in 2013, HB 391, and it made any Medicaid expansion that the state does has to get full legislative approval. So both the Senate and the House have to agree on a plan, and then the governor can sign it and implement some type of expansion. So he cannot go it alone. And then in 2014, after a couple of attempts of passing traditional Medicaid expansion or doing some other alternatives at no avail, Governor Herbert, at the end of the 2014 legislative session, he proposed what he called his Healthy Utah Plan. So when we started this, he originally wasn't on board with a Medicaid expansion, but after work and meeting people in the gap and hearing the stories and understanding the different problems, he really decided, okay, we're going to go for it, but we're going to do it a little differently. So that's his Healthy Utah Plan, and I'll get into what that looks like later. And then in 2015, so again, after a full legislative session with no proposal that was passed, the Committee of Six was created, or the Gang of Six. And so this was a joint resolution passed in the House and the Senate, HCR 12. And this picture here shows who is in the Committee of Six. So you've got Senate President Senator Shiozawa, who sponsored the Healthy Utah Plan, Governor Herbert, Representative Dunnigan, who sponsored an alternative called Utah Cares, Speaker of the House Greg Hughes, and Lieutenant Governor Cox. So those six are charged with coming up with a Medicaid expansion solution by July 31st. So what is Healthy Utah and what is Utah Cares? I'm just going to talk about these plans instead of going into all the other alternatives that have been suggested over the last few years. This is because these were the two primary bills that were being discussed at the end of the 2015 legislative session. So Healthy Utah is what we like to call an insurance expansion. So the income range covered is from 0 to 133% of the federal poverty level. And if an individual who falls in the gap has employer-sponsored insurance, because as we know, 62% of those folks are already working, so maybe they're offered employer-sponsored insurance that was just never affordable to them, then the state would use Medicaid expansion dollars and they would subsidize the cost of that employer's plan. So that employee would be put on the same plan their coworkers are put on, but the state helps pay for some of that program. If they do not have employer-sponsored insurance, they'd be put on a private market plan. So, you know, it'd be the same as, you know, Select Health or Arches or Blue Cross Blue Shield, whoever would decide to offer a plan to this expansion population, it would be that same private plan. And that's important to note because private plans reimburse providers at a higher rate, so you won't have providers shutting their doors saying they're not going to take Medicaid, because this is really a private plan, it's not Medicaid. And then for those who are deemed medically frail, so maybe they have a chronic substance use disorder or they have problems with activities of daily living, those individuals might be put on traditional Medicaid and be put into the accountable care organizations in the what is it, 12 counties that offer it, because they just expanded to 9. So it's really close to that. So then Utah Cares, so that's really a kind of a partial Medicaid expansion. So the income range covered there is a little different. It's 0 to 100% of the federal poverty level. And it would offer more Medicaid for a few more parents. So you'd capture a few thousand more parents in that because they would change eligibility from 0 to 50% to 0 to 64% of the federal poverty level. And then they'd also create a new eligibility category for those low-income adults without dependent children from about 0 to 33% of the federal poverty level. All of the rest of the individuals that are left out of those Medicaid eligibility levels would be put on PCN. So PCN is the state's primary care network, and it does not cover, you know, it's a bare bones insurance plan. So it's like having an insurance that would only pay for access to Instacare. So if you can get services from your primary care doctor, it covers 4 prescriptions a month, it covers birth control, family planning services, but what it does not cover is access to specialty care services like rheumatologists. It doesn't cover mental health or substance use disorder services. So it's really this bare bones plan that all of these individuals would be put on. So if you look at the comparison of the two plans that are being proposed, the covered lives in 2016 for Healthy Utah is about 72,000 lives, but the covered lives in 2016 is for Utah Cares is only 53,000. And again, that's because of the difference of the eligibility range. But what you look at here is only 18,000 lives would be put on Medicaid under Utah Cares, but 35,000 would be put on PCN. So this promise of health insurance, that's really just a promise to access to a primary care physician and nothing more. And then the cost to the state under Healthy Utah is only $25 million, but the cost to the state in Utah Cares is $64 million. And that's because of the way the Affordable Care Act funds an expansion of Medicaid. If you can get a plan that's approvable by the feds, they will give an enhanced match rate of 100% of the cost covered for the first few years, and then eventually it graduates down to 90% of the cost covered by the federal government and 10% of the cost covered by the state. So Healthy Utah qualifies for that enhanced federal funding, so it costs the state less. But Utah Cares, on the other hand, does not qualify for that enhanced funding. So the state would have to pay 30% of the state costs for a Utah Cares plan, and the feds would only pick up 70% of the state costs. So that's why you're seeing a huge cost difference there. And then the federal funds returned, for the same reasons, you get more federal funds returned under the Healthy Utah plan, $375 million, compared to only $83 million under Utah Cares. And that's important because we've had cost estimates done, economic analyses done, where under a Healthy Utah plan, where you get that much federal funding coming back to the state, they've estimated about 3,000 health sector jobs would be created. So think of mid-level folks like nurse practitioners, PAs, physician's assistants. So under the Utah Cares plan, our economy is not going to see that type of boost. So you definitely get a bigger bang for your buck under a Healthy Utah plan versus a Utah Cares plan. So, as I mentioned, this Gang of Six that was created, they have been meeting. It has been behind closed doors, really, because we've had these last 2 or 3 years an opportunity for the community to get involved. And so now they're kind of saying, well, maybe we need to do some horse trading or really hash out between the 6 of us some details that maybe we can't so much do in public. And that's not to say there's not an opportunity for public input, and I'll go over that later. But they've been continuing to meet, but it has been very private. They have flown to DC to meet with Health and Human Services Secretary Burwell. She's the main gal who needs to sign off on any plan Utah implements to determine whether it gets that enhanced federal funding. They have indicated in the media to meet the self-imposed deadline of July 31st, so what are we, 30 days away from that? So they have indicated a desire, and if they can meet that deadline, then there may be a special legislative session called in August. So some of the key hangups for this gang of 6 are really, you're going to hear cost, sustainability, and risk. So one of the main concerns that they have is that in other states that have implemented a Medicaid expansion, they've seen higher take-up rates. So of those eligible, how many actually enroll? Because the more people that enroll, the more cost it will be to the state. And so other states have had kind of a low take-up rate estimate, and so they're worried that because other states have done it, we will too, and so how can we bear the risk of that cost of it going over? And so you've heard from Senator Shiozawa, also from Speaker Hughes, that there's a desire to maybe have the hospitals kick in some money for that, because the hospitals, instead of seeing all these uninsured patients come through their door, all of a sudden are seeing all these insured patients coming through their door, who also, by the way, have a private health insurance plan reimbursing at a higher rate than Medicaid would. So maybe since they're receiving a lot of the benefits from this, they can kick in a little bit extra to help pay for the plan and mitigate some of the risk. Other industries that would benefit are pharmaceutical industries, and there's other ways that we can help pay for it too, but that's really where the conversation has shifted, is how do we mitigate the risk and cover the cost of the program. So the last thing I'm going to cover, and then Jason is going to talk about the Affordable Care Act and the subsidies on healthcare.gov, but one of the main things that I do, in addition to policy analysis and going into the details of what each plan covers and doesn't cover, is I do advocacy and coalition building. I should put coalition building on there too, but we help place Utah families and people who fall into the Medicaid coverage gap. We help them share their stories. We do this in a multitude of different ways, and a couple of them are outlined here. So we have, when the media needs a face of who falls into the Medicaid coverage gap, they call us. They're like, Riley, I need a family who's in the gap. Or Riley, I need a man who's in recovery, substance use disorder recovery in the gap. Riley, I need this, I need that. And so we have this story bank where we have all these people we've met throughout the years who fall in the gap, and we can help place them with the media. Because, and I'll say this when I meet with legislators too, we help people meet their legislators. I can talk to them, I can talk to the media, I can talk to legislators till I'm blue in the face and they know what I'm going to say every single time. That we need to do something, we need to close the coverage gap. But when they hear stories, personal stories of Utahns who fall in this gap, the problems that they face, the diseases that they have, the issues that they're having getting access to health care, that's when they start to care and they think, oh, this isn't just people who sit on the couch all day who just want free health care. These are people who, like Kylie, like I mentioned earlier, have undiagnosed diseases who need the insurance to get the diagnoses that they need so that they can get better. So we help place people with the media, we help take them talk to their legislators, we help people testify in front of committee hearings. We also do postcards. Folks can sign postcards and we send those to key individuals. 3 years ago I mentioned Governor Herbert was not on board with this, but we sent him probably over 500 postcards of Utahns across the state who had signed and said, I support closing the coverage gap. And I think that might have had something to do with his change of heart. And so now we're sending those postcards to Speaker Greg Hughes in the House of Representatives. And then the last thing I want to mention is that, this disease doesn't just affect people in Salt Lake County where I can come and meet you face to face. I mean, it's across the state, right? And that's why we're doing this electronic podcast, so you all can see this wherever you are in your homes. And so we do have this website that's set up. It's www.coverthegap.org. And there's a screenshot here in the middle of the screen here, and it's got a form letter. And you can change it up. If you yourself fall into the Medicaid coverage gap, type your story in there, and it will be sent to your legislators for you, to your senator and to your representative. It looks it up, so it takes that challenge of figuring out who represents you out of that and makes it easy for you. You can also find out way more information than I've covered about Medicaid expansion, the coverage gap. There's information on that website. You can read additional stories, people that I didn't cover that we've also story banked, their stories are online. And also, there's this fabulous tab that talks about groups who support the Medicaid expansion in Utah or closing the coverage gap. We work with the Multiple Sclerosis Society, we work with the American Cancer Society, AARP, Voices for Utah Children, so we've got older folks and younger folks. And so there's this great coalition that we've built over the years of different disease groups, different health advocacy groups, and we'd love to add your name if we can. But otherwise, just learning more about this and signing that letter is a really great way to get involved in this issue. And I don't know, do you want to do questions now since I've covered it, or do questions like later, after?
Any questions right now? Maybe that's one. I think there's a mic.
I don't know how to. Okay, cool.
You mentioned in a previous slide when you were comparing Healthy Utah and Utah Cares, and in Healthy, I think it was Healthy Utah, you said something about potential for medically frail to be put in a category.
Mm-hmm.
Can you talk a little bit about those categories, or is that going to be in his presentation?
So right now, the definition is it's a working definition, and the basis that I would tell you is that if an individual who is in this Medicaid expansion gap now, but we pass, say, Healthy Utah, and they indicate in their Medicaid application that they have problems with activities of daily living, so bathing, eating, preparing meals, those types of things. If they have issues with that, then they may qualify for traditional Medicaid. And that tends to be a more or an easier process for them to go through. It's an easier system as opposed to figuring out, do you have employer-sponsored insurance, which plan covers what you need under the private plans, and this puts them into an accountable care organization as well, where their care will be coordinated between the different providers offered under there.
Okay, so a follow-up to that is, I guess it begs the question, does that medically frail person need to be granted a disability status by the Social Security Administration in order to meet that category?
No, so they won't need to be diagnosed with a disability, and you're hitting on a point that I probably should have made, especially to this group here. So right now, in order to qualify for a disability, you got to go through this really lengthy process. It's terrible. You get denied, you have to appeal, and then even if you do get a disability ruling and you do qualify for Medicaid, you can't work over a certain amount of hours because you'll be kicked off disability. What this does is it takes care of that problem. So you won't have to qualify for a disability ruling anymore. You will just qualify for Medicaid or a private health insurance plan. You can work however much you need to feel self-fulfilled. I mean, because I had a conversation with a legislator the other day, and he met a person in the coverage gap who has a realtor's license. He is selling homes, but he's doing like maybe 1 or 2 a year, so it's not enough to get him help on healthcare.gov. But also, he hasn't gone through the process, or he's trying to go through the process of getting a disability ruling, but then he won't be able to work. But he likes working. So that's the problem right now with the system we have set up, is that there's these perverse incentives to either stop working and get a disability ruling, or to not take a job that's going to put a parent in that $10,000 to $20,000 threshold, and to just stay low income so that they won't lose their health insurance benefits. But this closes that gap, and there's continuous coverage at any level, any income level, all the way through 400% of the federal poverty level. There's going to be help available for those individuals.
Thank you. I'll just say that with our patient population, that's a huge hurdle, is getting the disability diagnosis. Many are in this state and throughout the country. They're often just denied all the way through, or it's taking them 7 years to get. I myself, I'm past 3 years now, and so But with Utah Cares, my understanding is that anybody that's in that medically frail, portion, it would just roll over to PCN. Is that right? Where
it depends on what income range you fell into. So it wouldn't really be based off of your needs. It would be based on if you're under, if you are a single adult without children, if you earn under 33% of the federal poverty level, then those folks would get Medicaid, but if you earn above 33% of the federal poverty level, you get PCN. And then that's also a perverse incentive because the services you need, like a rheumatologist, I'm assuming is a specialist, not a primary care physician, so you would want to stay under 33% of the federal poverty level to make sure that you can get all the full spectrum of services that you need.
So a single adult without children can get on that Medicaid part, or you have to have children?
Only under Utah Cares.
Okay.
Sorry.
No, that's okay. No, I know it's confusing. So yeah, only under Utah Cares, but
under Healthy Utah, you could get on Medicaid, or you could get a private health insurance plan. But under Utah Cares, you run the risk of getting on PCN, which is not going to cover the services that you need.
No, it doesn't at all, because all of the needs that that these patients have, they're all with specialists. They all require expensive testing. So it's almost, it's like not having anything at all, except for maybe unless you have a broken foot, then it might help with that. All right, thank you for clarifying that.
One quick comment I would make is that this still doesn't talk about accessibility to healthcare delivery. We still don't have enough physicians who are seeing patients, and that's one of our problems with our disease categories.
I wish I could help with that. Maybe one day we'll move on. All right, so Jason's going to come up and talk about those folks who earn over 100% of the federal poverty level and what services they can access through the Affordable Care Act.
Hello all, I'm Jason Stevenson from the Utah Health Policy Project. I do our ACA policy, or Affordable Care Act policy, as well as education and community outreach. Riley and I share an office, so we actually overhear about a lot of what we do, and so we can sort of do each other's jobs a little bit, but you're getting the best thing today because you got Riley on Medicaid, and well, you'll have to judge whether I'm good on ACA policy, but you already saw how good she is, so I'll try to be as good. Just to make sure we're all on the same page, what is the ACA or Obamacare, which is another way that it's referred to, or the Affordable Care Act? And I'll use all three terms interchangeably. The best definition we've ever come up with is that it is private insurance plans sold on healthcare.gov, and that's specifically here in Utah, with monthly premiums subsidized for some people. Now, some other states do it a little bit different. They run their own marketplace, so they have their own website, Cover California. There's another one in Colorado, Maryland. So, there's a little bit of variety, but over 30 states are like Utah and use healthcare.gov as our main portal for going and shopping for this insurance. And it is private insurance, which a lot of people don't realize. A lot of people think it's like Medicaid or Medicare or government insurance. It's actually, here in Utah, 6 private insurance plans that you probably know because you see their billboards and advertisements all over the place. So it's something that's actually more familiar. Now, how do people get insurance? Let's break that down a little bit. There's actually 3 ways that most people are insured. One is you buy insurance on the individual market, that top category. And I used to be a freelance writer. I used to write books and magazine articles. I didn't work for any company. So I had to go out and buy insurance for myself. So I fell into that category. It's not a big category of people in our country. It's only about 5 to 6% of Utahns, actually, and about that nationwide as well. You also get insurance through small group market. And that's if you work for a small business, like Foothill Family Clinic. They've got about 50 employees, so they buy insurance for their employees through what's called the small group market. But if you work for a bigger company, you're known as what's called self-insured. And that's where the company actually offers the insurance to their employees. It really is the payer. So if you break your arm and you work for Wells Fargo actually pays for your cast and for your rehab. It takes your premiums and it puts it in a big pot, and then when someone breaks their arm, they take that money and they use it to pay for the care. They usually use an insurance company to act as the intermediary and sort of handle all the paperwork, but the company actually bears the risk, and that's known as self-insured or self-funded. And that's usually companies over 300 or 400, but some smaller companies are actually moving into that now. That's really the 3 ways you can get private insurance. We also have Medicaid, as Riley just discussed, and Medicare. which is health insurance for those over age 65 for the most part. Some other people qualify as well. But generally it's what we call grandma and grandpa insurance. You know, it's for older Americans. The ACA only affects the individual marketplace. That's where that insurance is sold. Just that one small part, a very small part of how people get private insurance, which is one reason why maybe it isn't so popular, because it doesn't actually directly impact that many people. But it does it in a way for those people that it really does make their life a little bit better. Let's take a look at Utah's marketplace. This was actually one of the original slides we created about 3 years ago when we were figuring this all out, because states had a choice about how to approach the Affordable Care Act. There was a little bit of federalism involved here. Federalism means that federal government sets some rules, but then states get to make their own choices. And so Utah had a choice, and we actually did something that no other state did. We said we're going to let the federal government run our marketplace or our sort of shopping mall for individual and family insurance. That's through healthcare.gov. But we're going to keep control of our small business marketplace, which originally was called the Utah Health Exchange and is now called Avenue H. So we sort of split it up. The state takes the small business side, federal government takes the individual and family side. No other state did that at the time, back in 2012, 2013. Now there's a couple states that have followed this model as well, but we were the first and the only one for a long time. Now there's a bit of a scale difference between this. Avenue H, you can only get that insurance if you're a small business, and you're only if your boss brings you there. So you only have that option if you're working for a small business and your boss says we're going to go there. It covers about 12,000 lives here in Utah currently. Healthcare.gov, or the ACA insurance for individual and families, that covers about 128,000 lives currently in Utah. So we definitely had some more action going on in healthcare.gov. And that's really where UHPP and a lot of our work is focused. Because that's where you can sign up if like you're a freelance writer like I was, or working on your own, or an entrepreneur, or you work for a company that just doesn't give you health insurance. That's what gives you access to that insurance. Let's take a look at what's offered. And this is just in Salt Lake County. Back in 2014, there were 91 plans offered by those 6 insurance companies you see there. Very familiar names, some of the biggest ones in our state. In 2015, it jumped up to 101 plans offered by those same 6 insurance companies. All 6 of them stayed around. Then you see there's platinum, gold, silver, bronze, and catastrophic. Now that's not the Olympics. You know, Summer Olympics isn't for another year or 2 or 3 or something like that. That's actually the way they categorize these plans. You can see there's 34 or 40 silver plans, 27 gold plans. It's different ways that they're marketing these plans because the plans are a little bit different. And they're not different in the sense that a gold plan is better or offers better benefits than a bronze plan. It's different in how you pay for it. So a gold plan is going to have higher premiums, but it's going to have lower cost sharing, which means every time you go to the doctor, you're going to pay a little bit less for co-pays and getting a prescription filled and things like that. So it's a good plan for people who use a lot of health care. A bronze plan, on the other hand, is going to have low premiums, really low, but every time you use something, it's going to cost you more. The co-pay might be $30 for a prescription drug. To see a primary care doctor might be $50. Or for a gold plan, it might be $5 or it might be free. So bronze plans are designed for people who don't use a lot of health care because they save money on their premiums. And if they do need to go to the doctor on those rare occasions, well then they'll pay a little bit more, but they're betting by getting a bronze plan that they're not actually going to go to the doctor that much. So that's how they work. The benefits are pretty much the same across the board, and I'll actually describe those in a second. You can see the sweet spot is the silver plan, 40 plans there, and actually most Utahns, I think it's over 60 or 70% of Utahns that are buying these plans choose the silver plan because it's that balance between premium costs and cost sharing for buying insurance. So if all those plans are the same in terms of their benefits, what benefits do they offer? And this is an important part, especially those who are dealing with chronic fatigue syndrome and similar illnesses. These are the 10 essential health benefits. And after January 1st, 2014, any private insurance plan, both those sold through Obamacare on healthcare.gov and all those offered through private insurance, have to cover these 10 essential health benefits. You'll notice hospitalization there, number 3, maternity care, number 4, prescription drugs, number 6. It used to be a problem that people would go and they'd work for a company or they'd buy a plan on the individual market and they wouldn't read the fine print. And then they would get pregnant, and then they'd realize that their plan didn't cover maternity care. And I have friends in Ohio who had that, and story after story about plans that just didn't cover those things, because they just didn't know. It was sort of like an a la carte plan. Might have 7 of the benefits, or 3 or 2, and your premiums might be low, but if you don't realize it doesn't cover things, then you're really kind of buying at your own risk. But after January 1st, 2014, all plans have to offer these. And there's no reading the fine print anymore. They're in there. And actually, Utah used a state health plan, PEHP Basic Plus, as the rubric for building what the floor of these benefits had to be. So that we basically took a state health plan. State told all the private insurance companies, you've got to at least equal what we offer in this plan. You can do more if you want, but you can't go below the level of benefits in our PEHP Basic Plus plan. So that was how we came up with our essential health benefits. What's interesting is that you know, these are things you would probably say, oh, this is a good idea to have, but there's some people who are like, well, you know, I'm a 23-year-old guy, I'm getting insurance, and I don't want maternity care. Why do I have to pay for maternity care? And I get those kind of smart aleck questions every once in a while, especially when I'm in university. And so then I always ask them, so you've got a prostate, right? And they're like, yeah. And I'm like, well, guess what? The woman sitting next to you, she doesn't have a prostate. And you're going to one day need a prostate exam, maybe sooner than later, and she's going to pay for that. That maybe you should be paying for her maternity care in that case. So those kind of things, you know, you sort of realize that you have to have a broad definition of benefits because you don't know what you're going to use, and what you use, you might not, you know, your neighbor might not use, but everyone benefits by having these benefits. If we just had a la carte, then we'd have a very confusing and probably more expensive insurance business, or insurance premiums, especially for those who have a lot of health conditions. They would end up paying more where everyone else paid less. So keeping an even playing field actually helps. So where are we with the marketplace now that we've been in operation for 2 years here in Utah? Well, as I said, we have over 128,000 Utahns who have signed up on healthcare.gov. That's pretty good. You know, Utah's not a state that one would say embraces Obamacare, at least from a political standpoint, but in terms of signing up, they are. We're doing really well in the state, and we're finding some very interesting groups that are signing up, which I'll talk about in a second. Take Care Utah is actually the enrollment assistance group that UHPP is a part of, and we've helped over 200,000 Utahns with questions and with direct enrollment. People come in, maybe they have 1 or 2 questions, we help them with that, or they come in, spend a couple hours, and we actually sign them up. We have toys in our office, so the kids play with the toys while the parents sign up for insurance. We just had like 3 or 4 kids today doing that in our office. There were train tracks going all over the floor, a little dangerous to walk, but we'll put up with that. And Take Care Utah has done over 500 outreach and education events. Personally, I've done about 175 presentations in the past 2.5 years up and down the state, really trying to bring a just the facts approach to the Affordable Care Act. Because what we find out is that people walk into our meetings with their arms folded like this because they've heard about Obamacare. And what we say is, you know what, we want you to walk out of this meeting not loving Obamacare or the Affordable Care Act. We just want you to walk out of here understanding it more. And we do it just the facts. This is how it helps people. Take it or leave it, but at least you're getting the facts, and maybe they've been getting, you know, some non-facts from their crazy Uncle Joe's emails, which is one way that people get a lot of information these days. Here's some interesting things about who's signing up. #1 zip code for ACA enrollment in Utah is Daybreak, South Jordan. 2nd year in a row. #2 is Lehigh. 3 is St. George, American Fork, another St. George zip code. Obamacare is very popular in Utah County, is what we found. 7 of the top 10 zip codes are actually outside of Salt Lake County. This is during 2015, the second enrollment period. During the first enrollment period, 7 out of the top 10 zip codes were in Salt Lake County. So we're seeing a shift. As the news gets around, we sort of reached a saturation point in Salt Lake. Now the news is spreading to the other counties and people are signing up, and especially in Utah and Washington County. You can see that here. Utah County is up to 82% between 2014 and 2015. Washington County is up 87%. What's interesting is that Salt Lake County went from 31,000 to 48,000. Utah County went from 15 to 28. You know, that's Salt Lake still gained more, but you have to remember that Salt Lake County is twice the size of Utah County. So we're definitely seeing this surge happening in sort of more outlying areas, and one could also say more conservative areas of the state. And what it is that people realize that health insurance isn't political. Obamacare might be, but when you're making those decisions at your kitchen table about what insurance is about, what your family needs, how it can help you, you realize that getting to the doctor, getting to the hospital, and paying your bills is something that is beyond politics. And people are signing up in our state, which is great. So what are we doing next year? We're actually going to be leaving Utah and Washington County alone, they seem to be doing pretty well on their own. We're going to be moving into Davis, Weber, Summit, and Wasatch counties, Tooele, really hitting some of the areas that we know there's still great need, but maybe we just haven't gotten our message out there. We've already got 55 events planned for the upcoming fall open enrollment period, because the one thing about the Affordable Care Act is that you can only sign up for it generally in certain times of the year, what's known as open enrollment. So it's kind of a two-cycle system. During open enrollment, you can get sick on Monday and you can sign up on Tuesday. No questions asked. Pre-existing conditions don't matter after January 1st, 2014 for adults. And for kids, it was actually back in 2010. So you can just sign up. But those open enrollment periods are only for a limited time during the year. The one coming up is November 1st, 2015 until January 31st, 2016. So pretty much right over the holidays. So during that open enrollment period, you can get sick on Monday and sign up on Tuesday, no questions asked. But if you're outside of that, in what we call special enrollment, you need a good excuse to sign up, like losing your job and losing your insurance, having a baby, adopting a baby, getting divorced and losing insurance that way, moving into the state or moving within the state. Getting sick, unfortunately, is not a qualifying life event. So if you get cancer and it's July, it's not open enrollment, then you've got to wait for the next open enrollment period to sign up. And I know that sounds incredibly fair and crazy, that is a qualifying life event. That's probably the biggest life event you could ever imagine. The reason is that imagine if car insurance worked that way, where you have an accident and then you call up Geico and you say, I just had an accident, can you cover the accident I just had? Car insurance doesn't do that. They will only cover you after you have your policy. Health insurance during open enrollment will do that. So if you get sick during open enrollment, you can sign up no matter what. They'll cover your illness. But the reason they have special enrollment is they want to encourage people to sign up and not just wait until they get sick to have health insurance, but actually have health insurance all the way through so that when they get sick, it's there for them. Otherwise, everyone would just wait. I mean, imagine if car insurance worked that way. Everyone would wait until they have an accident and then go buy car insurance. Same thing with health insurance. Everyone would wait until they get sick and then go get health insurance. The market could not sustain that, either for car or health insurance, and everything would just collapse. So that's why they have this two-cycle system of opening and special enrollment. It sounds very unfair, but it's necessary to keep the insurance system operating. They couldn't function otherwise. And it's actually a good reason to have health insurance. And to be honest, I had a tree crush both of our cars on Monday morning, fell in our yard, and pancaked both of our cars. And I'm really glad we have car insurance because one was totaled and the other has $15,000 worth of damage. So I'm really glad that we have insurance. If we didn't have insurance, I would probably be crying right now. So I still am going to miss my car. But that's the value of insurance, and that's why you have it, because you never know when that tree's going to fall. I didn't expect it to happen on Monday, that's for sure. So Take Care Utah is the organization here in Utah that is designed and really set up to help people sign up for insurance, or really not just sign up, but if you have any questions, like I don't understand my deductible, or what is my insurance about, we can help with that as well. And the way to find these enrollment experts, and we have about 100 spread across the state, is to go to takecareutah.org or call 211, which is set up through the United Way of Salt Lake's offices. So you go there, you type in your zip code, a Google map pops up like you see right there, and you'll get the name, phone number, hours, and address of the nearest enrollment assisters to you. Let's say you only speak Samoan. Well, you can go and you can actually look. Presumably you can have someone read the stuff to you. You could go and find the National Tongan American Association. They're in our network. They have navigators that can help you in many different languages of Pacific Islanders. Let's say you have a disability. Well, we have the Disability Law Center here that will help people and understand disability issues better than other groups might. If you need a broker, you have a small business, we have brokers on our site as well. So really gives this statewide approach to connecting people to the enrollment assistance they need. TakeCareUtah.org or 211, it's completely free. And we're a little bit biased, but we think we're pretty good at what we do. Get Gephardt actually calls us sometimes when they have some issues, and we advise with them. And it's a good referral system we have. So now, King v. Burwell, Alan brought that up at the beginning of sort of the Supreme Court decision, which just came down. This was a presentation I actually created when we still didn't know what was going to happen. But King v. Burwell was a decision that could have actually taken everything that I just talked about and thrown it out the window. Taken away the subsidies, taken away the ability for people to get insurance in Utah and about 34 other states. So we didn't know what was going to happen. The Supreme Court ruled for King, which is the crown up there. Premium subsidies would have gone away. Some states would have gone alone, like Delaware or Pennsylvania, but Utah probably would have been stuck, and we would have had Congress come in with a fix, presumably. They ruled for Burwell, which is Secretary Burwell, the Secretary of Health and Human Services. That's her selfie picture she took of her bike helmet. Then the subsidies would remain, and this would become a presidential issue for the next presidential election, and it would have allowed more Medicaid expansion. Well, we know what happened is the Supreme Court ruled 6-3 for Burwell, which means we don't have to worry about any of the dire consequences that could have happened, and we can focus on continuing with the Affordable Care Act and moving forward with presumably Medicaid expansion if we can push it here. So remember how I talked about how the Affordable Care Act was also just for people with individual insurance? Well, that is the red part of this pie chart here. That 6% are in the private market. Those are the people who can really right now sign up for the Affordable Care Act, as well as the 15% that are uninsured. So it's about 20% of the populace here in Utah, although many of the people in the uninsured are in Riley's Medicaid coverage gap. It's not really her gap, but I'll just call it that. Those that don't qualify for these subsidies because they earn too little to actually get these subsidies, and I'll explain how that works in a second. But then you see 60% of Utahns have employer-based coverage. Well, they do benefit from some things. First of all, the essential health benefits we talked about, all of those employer-based coverage, they have to have those essential health benefits now. Pre-existing conditions no longer matter as well for employer-based coverage. It usually didn't, but now it can't at all. They cut the waiting periods for insurance for employers. Sometimes you would sign up for a job and they'd give you a 90 or 100 or 300-day waiting period before your insurance would start. That's been cut down to 60 days. They can't go beyond that. Technically 90, but really it's 60 days. So there are some protections for those that have employer-based insurance. Plus, if someone loses their job, which can happen, then they have the Affordable Care Act as a fallback option to go and get until they get a new job. And that's actually how a lot of people use it. So even though only 6, maybe 10, 12% of Americans or Utahns directly can sign up for the Affordable Care Act, it can be there to help them if they need it, especially those that might lose their jobs. Here's just an iteration of sort of how many people have signed up. Again, we're right now at 128,000. We dropped down from 140,000 because we went and we counted how many people have paid their premiums for the first couple of months, and we found out that, actually the federal government found out that 140 was sort of a big count, but when you actually count belly buttons in terms of people paying their premiums, you're actually at 128,000. So we had a decline of 8.8% nationally. That same decline was about 13%. So more people in Utah actually stuck with their insurance, and that's as of March of this year. We got that data just in early June. Now, what's happened with the uninsured rate in Utah since the Affordable Care Act took effect? Well, we went from 15.6% to about 13.3%. That's a 15% drop. Never happened like that in 1 year before, unless you go back to Medicare, Medicaid days, back to the 1960s. Nationally, the uninsured rate went down 20% during that same time period. Some states, like Arkansas and Kentucky, they not only expanded Medicaid, which we're still waiting on here in Utah, but they embraced the Affordable Care Act. Their uninsured rates went down 50% in 1 year. They went from 20% to 10%. So actually, Arkansas and Kentucky have lower uninsured rates than Utah has right now. We're still ahead of Texas. They're at 25%. I think we'll be ahead of them for a while. But you can see the impact that putting more people on insurance has had. Now, do all of those 128,000 Utahns who signed up for the ACA, were they uninsured before? No, some of them did have insurance. For instance, my nanny, the woman who watches my son, she had insurance. She was paying $800 a month for her insurance policy because of pre-existing conditions. Actually, her pre-existing condition was that she used to weigh 450 pounds and then she got bariatric surgery and now she weighs 150. So she's doing great, but it was a pre-existing condition, and so they still were going to charge her tons of money even though she was living healthy and did the right thing and paid for her surgery out of pocket, $40,000 a couple of years ago. Her insurance went from $760 a month to $225 a month through the Affordable Care Act. Pre-existing condition didn't matter as much because she's 60 years old. She actually pays less because the age range went down, and she gets a subsidy, which I'll describe in a bit. So she was insured before, barely, and now she's still insured, but she's paying a lot less, and she's starting a college savings account for her grandkids. So, she's able to take that money and actually reinvest it in her family. Here's how those subsidies work. This is a different side of the age equation. This is the Shumway family from American Fork. Dad's 24, mom's 23. They just had a baby, so they signed up for insurance. They make $44,000 a year for a family of 3. That puts them at about 220% of the federal poverty level. Now, poverty level really never used to matter for insurance, but it matters now for the Affordable Care Act, and it certainly matters for Medicaid as well, because if you fall under 100% of poverty or under the poverty level, you are in the coverage gap. So all of a sudden those numbers become very important for people's livelihoods. So the premium, if they bought a silver plan, remember those silver plans are the most popular plans? If they bought a silver plan, the premium would have been $479 a month for the three of them. But because they're at 220% of poverty, they get a subsidy because the subsidies are based on sliding scales. Their subsidy is $218 a month, so they pay $261 a month for their insurance. So they're able to afford their insurance a lot better. That covers mom, dad, and baby all on the same private health insurance plan. You can see the deductible is $2,500. Primary care doctor is $25 copay. I think emergency room is a $500 copay, so that's pretty steep. But you know, if you go to the emergency room, you just want to make sure it's an emergency. That's a good reason to have a large copay there. So this is how the Affordable Care Act helps a young family stay insured. And we see these families, and we see older families, and all kinds of families who have the same kind of experience. The subsidies are sliding scale. So let's say he or she gets a better job, they earn more money, well, their subsidy would go down a little bit, and they would have to pay a little bit more. Or they lose their job, and they have to take another job that's lower paying, their subsidy would go up to compensate for that. So the subsidies are adjustable and sliding scale based on income and family size. Let's say they had twins. Maybe they got a surprise. My wife's got to give birth. I hope we don't have twins. We don't expect it. We're not ready for that. Their family would go to 4. Well, their family size of 4 would also adjust their subsidy. It's sort of this ratio. It sort of moves back and forth based on income and family size. So that's how the Shumways are insured. And to be honest, when I go around and do these presentations, when I put this slide up, that's when you'd see people uncross their arms. That's when you'd see people really lean in and understand how this works. Because this is a family where $400 a month would have probably been a reach for them to get insurance. But $260, they could probably swing that. And so this family can be insured on private insurance. And these are the families we're seeing in Utah County, in Daybreak, in Washington County that are signing up for insurance. So here's a couple stats about who's signing up. It's a lot of families like the Shumways. 54% of Utahns signing up are under age 35, compared to 36% nationally. So we have a younger population in our state. We know that. That younger population is signing up. And you know why that's good? It's because younger people tend to be healthier, and that balances out the risk pool and makes our risk pool more sustainable. Because younger people are paying their premiums, but they're not going to the doctor as often. So that really helps our risk pool stay better, and actually causes insurance premiums to stay stable as well. 67% of Utahns are getting a subsidy that are signing up on healthcare.gov. We actually think that number's a little low. We have a query back to the Washington, D.C., because we used to be at about 88%, and then the most recent data came out at 67. We think there's some sort of data glitch there, so we're getting that checked on. But right now, we at least know that 86,000 Utahns are getting subsidies. We think it's probably closer to about 100,000, but we'll get back to you on that once we get the higher number. We're probably more on par with the national number, which is about 85%. Out there. The average subsidy in Utah in 2015 was $208 a month, which means that the average, that family got a $19 subsidy. So that was a little on the low side. The average subsidy per person is actually a little bit higher. And the subsidy covers about 64% of the premium. So with King v. Burwell, we were facing the removal of that 64% of the premium going back to the policyholder, which would have made it unaffordable and would have caused tens of thousands of people to drop their insurance. So that was why it was a very important decision here. And that wraps it up, although I do want to add one more thing, and to reiterate what Riley has discussed, access to doctors, access to specialists is really the reason we have health insurance, right? It's something goes wrong, we need to get it checked out. And if you don't have health insurance, then it's really hard to get in that door. Both personally, to realize that you could be on the hook for hundreds or thousands of dollars, and because of just how you're viewed by a doctor or by a provider when you don't have health insurance. They don't necessarily always treat you as well. My wife's a family doctor, and some of it is the fact that they'll tell you, you need to go get an MRI, you need to go get a CAT scan, you need to go get this done, and you can't do it because if you don't have insurance, you can't afford it. And so those doctors feel very frustrated because they can't relay you or send you on to get the care you need. So health insurance is more than just a card in your pocket. It's the gateway to better care. And that's one reason why we're really excited that so many Utahns are signing up, and why we want to close the coverage gap to get everyone with that same access to the help that they need whenever they need.